ladies and gentlemen. First of all, thank you all for coming to Medicine Grand Rounds on this illustrious day. And I hope that my purpose today is to increase your awareness about celiac disease and to convince you that we are missing a large number of people with celiac disease, because if you say that you haven't seen one in your clinic, you're probably wrong. You probably have seen one, you just didn't recognize it. So it's important to think about. We are actually seeing an increasing incidence, which is kind of probably mediated by several factors, and we'll talk a little bit about it. So you say, why would a little bitty gastroenterologist be interested in celiac disease? Well, one of the reasons, of course, is that short stature is a common process of celiac disease. Now, as it turns out, my whole family's short, so it eventually did, though, come through in the family. So I'm going to start by talking about a case, and this case happens to be near and dear to me. We have 6 grandsons, but we only have 1 granddaughter. So she is, of course, the princess. And at the age of about 2, the princess was visiting. And she was a little bit before 2. And we were over at my son's place in Dallas, and we were all getting ready to go out. And my daughter came down and she said, "Stop, we can't go anywhere for just a little while. Amelie has had a punami." A punami. I said, "What's a punami?" Well, a punami is when it fills the diaper, goes up the back, gets in the hair, and both mother and daughter have to have a shower. Okay? So think about punamis. Now, I did know that she had a bit of a foul-smelling, bulky sort of stool that seemed to coat the toilet bowl from time to time when you cleaned the diaper out. But she also was having some other troubles that we really didn't think about at the time, since the diagnosis was not yet made. Her hair wasn't growing. So she was a little bald girl with ears that stuck out like her mom called her. She says, "Here's Dumbo, the elephant." And she was having trouble running the way the other kids ran. My daughter called and said, "You know, I just don't think she's running right." And so we took her to see the pediatric orthopedic surgeon, who said, "Everything's fine, don't worry about it. She's only 2 years old. Come on, give you a break." So she was kind of a little bit more clumsy. And we thought, does that mean anything? And she had funny, bloaty abdominal pain. She'd, cry from time to time and so on. So that went on. She went home to Cambridge, where she lives, and probably close to a year later, she came down. And now, of course, she was doing really quite well. Her hair still wasn't growing very much, so she was still kind of a little bald girl. But she was run over to the cupboard, she would get out a bowl, and she would run to the ice maker, and then she'd sit down on the floor and eat ice. And my wife said, sometimes that means that they're iron deficient. And her dad said, "Oh, she's profoundly iron deficient. In fact, I'm putting iron in this pudding," and he, being a PhD acoustical engineer, was creating a database about how much of the pudding she had eaten, so he would know how many milligrams of iron she had actually ingested. And he said, it's very frustrating because she doesn't always eat all the pudding. So she was profoundly iron deficient. And that did it. I said, wait a minute. Punami's iron deficiency, she's got celiac disease. It's a typical presentation. And my daughter said, oh, no, she has milk allergy. Her doctor, her pediatrician, is a pediatric gastroenterologist who has a celiac clinic. And he says that this is milk allergy. And I said, well, I don't know. It looks like celiac disease to this old guy. So maybe you could get him to kind of test or just humor me. And indeed, she did have celiac disease, which caused profound apologies for missing it. And so she began on the treatment for celiac disease, which is a gluten-free diet. And if you take 2 PhD parents and a single child, and there is not a molecule of gluten that has come within the walls of that house for the next several years. And she's now 7 years old, looks perfectly normal, runs around like crazy, plays piano, plays soccer, does all those good things. Her clumsiness has gone away, and she's in a completely normal development. She does ballet and ballroom dancing, so you know that her coordination's fairly reasonable. And she knows gluten-free better than anybody in this room, including me. She goes to the store and she'll say, Papa, is this gluten-free? Can I eat this? Because she knows what's gluten-free, and she knows to stay away from it. So, with all of that in mind, I thought we should talk about celiac disease. Now, you say, wait a minute, this is not pediatrics. This is not pediatric, it's not? Children are humans too, okay? I know sometimes it seems unreasonable to think so, but in fact they are humans. And children do get celiac disease, and the way that we normally found celiac disease was with this kind of a profound demonstration. But today, what we're seeing is different. Today we're seeing celiac disease in people who are 25 to 45, not as children. And they don't always present with diarrhea and all these symptoms. And so we're going to talk about that. And that's why I'm telling you that they're in your clinic and you don't know it. And so every time you see these things that they seem to present with, that you will have in your mind by the end of this discussion, you need to think about celiac disease. And it's really simple to just send off the celiac panel and get it tested. It's really simple. You don't have to go and do a small bowel biopsy. You don't have to send them to us for a duodenal biopsy. You can you can measure the celiac panel, TTG, and so on, and we'll talk about that. So what is celiac disease? I want you to remember these two top lines. Gluten-sensitive enteropathy, okay, just tells us that it's gluten-induced, and the actual manifestation is crypt hyperplastic villus atrophy. So as soon as you see the word celiac disease or think celiac disease and you begin to think crypt hyperplastic villus atrophy, then you'll know the pathology. And when you know the pathology, you know that it's in the upper GI tract mostly, then you will be able to figure out the physiology of what doesn't get absorbed and therefore what are the effects. So obviously it's going to be things like iron and calcium and the vitamins and so on. And if they don't absorb, they're going to overwhelm their colon, they're going to get diarrhea, they're not going to absorb the fat, so it's going to be bulky and it's going to be steatorrhea and it's going to float. And it's going to be greasy ring around the bowl. Okay? And it's going to be hard to flush. I had a lady one time that had all these, and I thought, she must have celiac disease. And I said, how many bowel motions do you have in a day? And she said, just one. I said, one? You only have one? Yeah. Is it big? Well, yeah, it's big. I said, how big? Well, big. I said, do you go and then have to flush and then go some more? Yeah. So 2 bowls full? Yeah. I said, do you have to go more and then flush again? Yeah. So, well, how many bowls full? She said, ooh. She's like Baba Black Sheep, you know, 3 bowls full. So 3 bowls full, but only once a day. And I said to her, is it stinky? Oh, yeah. I said, what if you were at a party? Would you go into the bathroom and go? She said, no, I would get in my car, I would drive to a service station, and I would go there. Because no one would want to go near the bathroom after I was done. And I might plug the toilet. which happens all the time. So bulky, foul-smelling steatorrhea stool. They float because, of course, they've got gas in them, right? They don't float because they got fat in them. Fat doesn't cause something to float up. Fat will float on the top of water, but fat doesn't cause stools to float. Okay? So it's like a submarine. If you increase the pressure in the toilet, or if you put the stool in a glass cover in a bowl of water, and you push down on the membrane on the top and you increase the pressure, the turd will sink like a submarine. Okay? So you remember that they're going to have excess gas now. So now we've got a lot of things going on in their mind. They're going to have bulky stools and malabsorption and fat. They're going to have sometimes punamis. But you can see that this was an adult punami. You know, it was kind of neat. Well, who in the world gets it? Lots of people have these two loci, DQ2 and DQ8, but they don't get celiac disease. But everybody who gets celiac disease, or almost everybody that gets celiac disease, if not everybody, has one of these two loci. So if you're really in a corner and you're really trying to figure out, does this person really have celiac disease? If you do the genetic testing and they're negative, they don't have celiac disease. If you do the genetic testing and they are positive, they may have celiac disease, but it doesn't make the diagnosis for you. These are on this chromosome 15q26, which is actually the same, interestingly, the same one for type 1 diabetes. And so therefore, there's another factor that we need to remember, that all our patients with type 1 diabetes, whether they be children or adults, should be tested for celiac disease, because the genetics are similar, and so the incidence is actually similar. So we need to be thinking about that. How do we make the diagnosis? Well, there's an autoantigen. This is an autoimmune disease, just like autoimmune thyroiditis, just like type 1 diabetes. These things are immune mechanisms, and that's why the disease is so important, and that's why being gluten-free is so important. Because if you see just the smallest amount of gluten, it's going to trigger the immune reaction. So it's not like you can see a little bit of gluten. That's like being a little bit pregnant. You can't have any gluten. It has to be absolutely gluten-free. Just within the last while, one of the local internists told a physician or a surgeon who has celiac disease, well, now that you've got it under control, you can have some gluten now. It's absolutely wrong. You cannot have gluten. And until we do find something else, you must remain absolutely, completely gluten-free. So part of the process is this autoantigen that forms to tissue transglutaminase. Now, transglutaminase is in the endomysium, in the cells. And thus, this is a similar thing, not exactly the same, but similar. This is part of the anti-endomysial antibody. You notice that I didn't say it was part of the anti-gliadin antibody, because it's not. The gliadin is the part of the gluten. So this is the anti-endomysial antibody. And this is the TTG that is the key to making the diagnosis. So we can measure, obviously, like we can for so many other things, both IgA and IgG. But in fact, the IgA antibody is more important and easier to get and to do. But if you're stuck and they have selective IgA deficiency, which a number of people with celiac disease do have, if they have, and that's why if you order it and it's kind of borderline, the lab will add on an IgA for you so that you don't have to reorder it. So if they have selective IgA deficiency, the IgA antibody can be a problem. So you can either measure the IgG, or you can measure an IgG antibody to this deamidated gliadin peptide. which is usually done with IgG. So you can measure anti-endomysial, anti-TTG, or anti-deamidated gliadin peptide. And this is particularly helpful, this last one, in the children's population, which was an interesting thing. When I told my kids that I thought she had celiac disease, their question to each other was, what does Daddy know about children? But Daddy was right. Okay. Well, what about this TTG stuff? This is kind of interesting. So TTG facilitates the cross-linking of this glutamine proteins. And then this in itself deamidates the glutamine residues, and that's how you get the antibodies to it. And then you get this increase in the negatively charged peptides, the gluten peptides. Now, these peptides actually bind to the HLA stuff, okay? So that's why the HLA is so important, the DQ2 or DQ8, because it's involved in the actual immune process. This product stimulates T lymphocytes, and the T lymphocytes are the things that create the damage to the mucosa. And they create it by impairing the actual mobility of the cells down in the crypts, migrating up to the top of the villi. And so that's why you get these flattened, broad villi. And the T lymphocytes you see in the lamina propria. So you see these increase in T cells in the lamina propria and the flattening. And this is all mediated through TGF-beta. Now, TGF-beta itself is activated by the TTG, and this is what governs the epithelial differentiation. So if you have an antibody to the TTG, then you don't activate your TGF-beta 1, and therefore the cells don't migrate and don't mature, and that's how you get the flattened villi. So it's kind of an interesting mechanism. Now, this is what's known about it so far. When I first did get interested in celiac disease about 5 years ago, this wasn't known. So we're making some significant progress. So the antibodies inhibit the stimulation of the TGF-beta 1, and therefore you get the less differentiation of the cells. Now, gliadin receptors affect the gliadin transport, okay, the absorption of the gluten, the gliadin. Gliadin is the acid soluble part of the gluten. And so gliadin tends to accumulate. And this also activates T cells, and this also then contributes to the damage to the membrane. Now, this activation may be why some people, even if they don't have celiac disease, may well be sensitive to the amount of gluten in their diets. So my other grandchildren went to visit Amelie, and of course they had to be absolutely gluten-free for a week. And when they got in the car to go home to Texas, they said to the 12-year-old, "What do you want to stop and have lunch?" He says, "What do you want for lunch?" He said, "Gluten. I want gluten. I don't know what it is, but I want it. I have been without it for a week." So a gluten-free diet is a big deal. It's a very difficult diet. And we'll talk about why in a few minutes. Okay. So then there's these other funny things. Now, as wheat has been grown, wheat has pests. The birds like to eat it and so on. So there's a resistant protein in the gluten cereals, and this can increase inflammation. And this may be related to the non-gluten or non-celiac gluten intolerance too. So these are amylase trypsin inhibitors that get in there. I don't know whether this is all new, but then this whole field of non-celiac sensitivity to gluten, and there's a whole sort of cult building up around this gluten-free diets. And a lot of the gluten-free material is being driven by this demand for gluten-free stuff. So if you go to, for example, Drug Emporium or so on, you see this huge gluten-free section. But always warn your patients in that gluten-free section to read every label, because there are times when there is a non-gluten-free product that is made by the same company as a gluten-free product, and it may be in there. Okay, so we talked about this cross-linking and then deamidation of the glutamine residues. Remember that the HLA DQ2 and DQ8 are involved. Remember there's T cell stimulation, and these T cells trigger the response. So remember that the TTG is in inflammatory cells, and so if the T cells get turned on, they can produce the TTG in themselves, and it's also produced in the endothelial cells. Oh, I'm going backwards, that's why. This didn't make sense. Okay. No, I'm not. This is supposed to be forward. Okay, so let's talk a little bit about incidence. When I was a young physician, we thought that you really only saw celiac disease in people of Northern European extraction. You know, we talked about the Irish, the Scottish, the Nordics, that sort of thing. We didn't think it was anywhere else. And we thought the incidence was somewhere in 1 in the 4,000 people. Wrong. We've now discovered that it's a whole lot more. Now, today, the current, the most recent data that I have is 1 in 137 people. So think of the number of people that are coming to our clinics. We also now know that it occurs in blacks, in African Americans, in Chinese. We know we had a visitor from the Punjab in India, and we had absolutely no idea when he came, but he said that celiac disease is a huge problem in the Punjab, and it's all because of the Americans. And we said, well, you know, we didn't have enough food production, and therefore the Americans came and they introduced us to this new wheat, and now that we've got this wheat which grows faster and is resistant to the pests and so on, we now have a stronger, more protein wheat, and all of a sudden now we've got lots of celiac disease. So it's the Americans' fault. Well, we didn't really think it was the Americans' fault, but now it's in all origins. So it can be in any of your patients. It doesn't have to be in that person whose heritage is Northern European or British Isles. The original case was described in the 1st century, actually, back in Italy. What about families? Let's say you've got somebody who has celiac disease. What about their relatives? What are the chances? Well, in 1st-degree relatives, 1 in 22. 2nd-degree relatives, 1 in 39. And even if they're asymptomatic completely, then the incidence is 1 in 56. 75% of monozygotic twins, not all of them, interestingly enough. SIBs, 40%, 1st-degree relatives. So there's a whole bunch in relatives. So if you have somebody in the clinic whose relatives have celiac disease, start looking and thinking about it. Well, what symptoms are we going to see? Well, we've already talked about some of them, but we're going to see belly pain because of the bloating and the gas and the bulky stool and that sort of thing. We're going to see some weight loss, although you can have fat celiacs, okay? They don't have to be skinny. You can have fat celiacs. And interestingly enough, when the fat celiacs go on a gluten-free diet, they lose weight. When the skinny celiacs go on a gluten-free diet, they gain weight. So it goes in the proper direction, interesting. They often have steatorrhea, and you have to ask those funny questions like, do you plug the toilet? Do you have to flush more than once? Do you see a greasy ring around the bowl? Do your stools float? That sort of thing. And they often have vitamin deficiencies, and those vitamin deficiencies, any of the fat-soluble vitamins because of the malabsorption of fat, any of the B vitamins because of the loss of surface area in the upper GI tract. What about the signs? Well, weight changes, iron deficiency, anemia, osteopenia and osteoporosis because they malabsorb vitamin D and then calcium in addition to that. You see growth failure. You see deficiencies of the fat-soluble vitamins. There are neurologic disorders and psychiatric disorders that are related to it, including peripheral neuropathies. And then anytime you see somebody with another autoimmune disease, then you should be thinking about celiac disease too. So it's really worthwhile testing these people to see if they've developed them. And Dr. Levine was telling me that they test all these people and they haven't found any, but we've tested them. The most, we found a celiac disease in our clinic within the last 3 or 4 weeks. The oldest person I have found with celiac disease was 65 years old. And so it can go along. And he presented with iron deficiency, having been scoped both ends 3 times, had a capsule, had 3 CT scans, and he was still iron deficient and no source. So, you know, triggered my celiac disease thoughts, and boom, that's what he's got. Now he's doing fine. So what kinds of disease do we have? Well, we have the classic, like Amylase, with the symptoms and with the abnormal duodenal biopsy. We have non-classic disease, people who have, for example, an abnormal biopsy but normal serology, probably are very rare, but people with abnormal serology and a normal duodenal biopsy are more common. So you may see those. You may see people who have positive serology but don't have any symptoms, any signs, and their biopsy looks okay. And that can be latent or potential celiac disease. You may see people with this positive anti-endomeasial antibody and a normal biopsy, and you wonder what to do with them. They still probably have celiac disease, and they probably will get better. You know, it used to be that we thought you needed to get way down in the small bowel to do the biopsy, but now we realize that it's abnormal in the upper duodenum. We can just do it with a scope, and there's even abnormalities within the first portion of the duodenum, the duodenal cap. So what do we see? Well, sometimes we can actually see that the villi are not there, and particularly with our new high-resolution scopes we can see that. We sometimes see scalloping around the edges of the valvulae conniventes. But on biopsy, we see the crypt hyperplastic villus atrophy and the intraepithelial lymphocytes. Well, what about subclinical disease? Well, they may present with iron deficiency. They may present with just a mildly elevated liver enzymes, AST and ALT, type 1 diabetes, some collagen diseases, ataxia, depression, anxiety, seizures. You know, I'm naming all the things that you see in the clinic, right? Osteoporosis, diabetes, skinny, obesity, that sort of stuff. You may pick it up with metabolic bone disease. You may see a male, for example, a fairly young male who has osteopenia. And that's how the surgeon got picked up. He was relative middle-aged surgeon, goes in, he has a bone density scan because he had some pain in his bones, and he's got osteopenia, and they said, well, geez, why is that? Sure enough, he has celiac disease. These people get secondary hyperparathyroidism, and so they may have an episode of pancreatitis, for example, which should trigger us to thinking about it. They have hyposplenism, and they should be vaccinated, just like anybody with hyposplenism. They may have arthralgias or arthritises. They may have any of the autoimmune diseases. They get deposits of IgA in the glomeruli, but they don't often go into renal failure because of it. And then they get this Lane-Hamilton syndrome or pulmonary hemosiderosis that actually gets better when you go on to the gluten-free diet. The classic, of course, is Dermatitis Herpetiformis, or DH, which are the little congregations of itchy vesicles that you'll see in the biopsy, or the dermatologist will tell you what it is. And what they see in those are granular IgA deposition. Again, gets better with a gluten-free diet. Anybody with DH has probably got celiac disease, but most people with celiac disease do not have DH. Down syndrome has a 16% incidence of celiac disease. Isn't that interesting? And I'm not sure that we understand exactly why, but it's probably genetic. People with selective IgA deficiency have a higher incidence. We talked about the thyroid disease, the liver disease, and there's interesting inflammatory bowel disease. Now, people with celiac disease may well develop collagenous colitis or lymphocytic colitis and inflammatory bowel disease. But of the people who have inflammatory bowel disease, very few of them have celiac disease. So you would go one way but not the other. One of the interesting things is infertility. Both male and female infertility can be a clue to celiac disease. And then they can actually get some myocarditis, and so you can get cardiomyopathies. How do we make the diagnosis? We talked about the anti-TTG antibody. There's a good sensitivity and specificity for that. The amidated gliadin peptide, particularly in children, or particularly in people who have selective IgA deficiency. And then, of course, the small bowel biopsy, which is the sine qua non. But not everybody who has celiac disease needs a small bowel biopsy, although, of course, I would be delighted to do it. So think about the risk of autoimmune disease. In a group of 924 patients with celiac disease, 178 had some other autoimmune disease. And if they looked at the ages at which they developed them, 8.1 and then 15% at the two different ages. So as they get older, they're more likely to develop another autoimmune disease process. What other things can we have? Well, lactose intolerance, irritable bowel, bacterial overgrowth syndrome, because the villi are not normal and the actual mechanisms of the gut are not normal. They can develop pancreatic insufficiency and microscopic colitis that we talked about. Well, what if you treat them and yet they still seem to have the disease and their antibody stays up? Well, the most common thing is that they're seeing gluten somewhere. And so you have to just go over the gluten-free diet, over and over and over. And the dietitians are a pretty reasonable resource for that, but there's nothing like an obsessive parent to look after a child, to check everything. I mean, my daughter goes to the point that if she doesn't know the product is gluten-free, she'll call the company, and she'll make sure, she'll talk to the director at the company and ask them, and make them prove that it's gluten-free. Okay, so what happens if you're sure that they're gluten-free and they still have ongoing? You worry about abnormal intraepithelial lymphocytes, particularly the T cells, and these are the ones that can go on to the enteropathy-associated T cell lymphoma. Now, this is rare, but it does occur. Now, I remember a lady when I was in practice over in Bossier who I was absolutely convinced had celiac disease, and she would not follow a gluten-free diet. In fact, she would go to the point of making cookies and bringing them to me to prove that she was not following the gluten-free diet. And several years later, I met her, and she was being treated for her enteropathy-associated T cell lymphoma over here at our cancer clinic. Collagenous sprue can occur, and that can give you a continuing diarrhea in spite of being completely gluten-free. And sometimes you need to use either endoluminal steroids or oral steroids or immunomodulators to treat it. So that's what you think of when you can't seem to get control of the disease. Okay. This is a nasty disease. 5-year survival of 10%. For a lymphoma, that's a bad disease. Lymphomas are generally more treatable than that, but this one, for some reason, is particularly nasty. All right, so how do we treat? Well, gluten-free diet, we talked about that. So you avoid wheat, barley, rye, and it has to be an absolute avoidance. You notice we didn't say oats, okay? Oats are okay. But with the oats, you have to be careful that they're not processed in a plant that processes wheat, rye, or barley. Interesting. Now, Canadians are particularly prone to drinking rye whiskey, but it doesn't have any gluten in it, so it's interesting. Pneumococcal vaccine, you should give them. Surveillance for other immune diseases, DEXA scanning, we talked about. Vitamin supplementation, both the B vitamins and the fat-soluble vitamins. You should spend most of your time in following them, talking about their gluten-free diet and how well they're doing. You need to stay away from barley and bulgur and durum and farina and graham. No graham crackers for you. Matzah. Stay away from that. Rye, semolina, spelt, triticale. Any of those things. That's a lot of stuff to avoid. So what do you got to stay away from? Well, beer, breads, candies, cakes, pies, cookies, cereals, crackers. No croutons on your salads. Gravies. Gravies have flour in them, right? Anything that's got flour in it, if you don't use rice flour or corn flour, you've got to stay away from it. Oats are okay, and the question about that. Any of the imitation meats, you know, the manufactured meats like the artificial crab, that sort of thing, often has it in. Most pastas that we eat are wheat. Any processed meats have flour in them. Salad dressings, sauces, self-basting chickens, turkeys, and most soups have a flour in them too. Now cornstarch is okay, but most of them have flour. Malt flavoring, like as in malt vinegar, right? That Canadians put on their French fries. Any modified food starch, lipstick, lip chapstick, lip balm has gluten in it. Meds with gluten binding, and there's this website where you can go to gluten-free meds. But if there's any doubt and your patient's taking something and it seems to be affecting them, call the company and find out if there's gluten in it. Play-Doh, crayons. Crayola crayons are gluten-free, by the way. So get the good Crayola crayons. 64 pack of crayons. It's okay. And remember, we used to eat the crayons in school? Well, that's not good for a celiac. Toothpaste has gluten in it. Toothpaste. You got to look at everything. The other thing they got to think about is cross-contamination. Anything that's cooked that is not in a gluten-free kitchen can pick up traces of gluten. Okay? You can't use a wooden cutting board that people cut bread on to cut the gluten-free bread that you buy at the store or that you make in your bread maker. When we go to a house or so that we do for a vacation, they take all of the preparation stuff, all of the cooking stuff, all of the cutting boards, everything goes into a room and it's taped off like a crime scene. Everything that we use is brought in. I mean, this kid hasn't seen a molecule of gluten in a long time. Grill surface. Lord, think about it. Somebody cooks something on the grill, puts the hamburger buns on the grill, contaminates the grill with gluten. So you have to have a whole grill. You can get around it by putting tin foil on the grill, you know. Cutting boards, utensils, any of the condiments you got to think about, any of the surface. If you touch a piece of bread and then you touch the child, you may have some traces of gluten on I think it was funny, my daughter made me wash my face after I ate a hamburger, so in case the grandchild kissed me. So I don't know how much all of that's really necessary, but it certainly makes sense when you think about the mechanism and the immune part of it. Well, what can you have? Arrowroot, buckwheat, amaranth. I have never had that. I've had most of this other. Corn, hominy grits, of course. You know, grits in the South, cornmeal. The gluten-free flours like rice and soy and corn, potato flour, bean flour, polenta, quinoa. Quinoa has become significantly popular. Quinoa is a grain that is raised in the mountains, generally in Peru. And when they brought the quinoa down from the top of the mountain and modified it so that the little shell on it would let it grow faster, the birds loved it. But once they took it back up into the tops of the mountains and it had the little shell on it, birds wouldn't eat it, so they had to actually now, and they still grow it up on the top of the mountains. Tapioca. Any meats, fish, and poultry are fine as long as they're not processed meats. Milk is fine, cheeses are fine, potatoes, rice, vegetables, so that's not too bad. Wine's okay, beer is not, distilled liquors are fine, ciders are okay. So those things, that gives you a little bit. There's now gluten-free beer, by the way. There's at least 2 manufacturers of gluten-free beer. Well, what about as they go out? What about going to school? Well, not only do you have to pack a lunch for the kid, but the whole school needs to be really gluten-free, or at least there has to be an area where she has a safe area where other kids are not bringing their sandwiches. And of course, you know, kids trade their lunches and all that sort of thing. You've got to really be careful about that. Go to friends' houses. Do they have a gluten-free way of doing it? You take meal. You go out to somebody's house and the kids with you. You need to bring a food for them. You can't let the other kids share their food. Restaurants. And in the restaurant, it's not just the ability to make the gluten-free product, but they have to have a section in the kitchen that is absolutely gluten-free. If it's not gluten-free, there's hardly much point. And so you have to know the restaurant. When we go to Ben & Jerry's for ice cream, we tell them you have to open a new container, use a new scoop, and no cones, because the cones have gluten in them, so it has to be in a bowl rather than a cone. I mean, it's an incredible change in life. Sporting events, take a picnic. One of the people that I talked to, an adult who has celiac disease, said when she travels to a meeting, for example, 1 suitcase is full of food so that she can have gluten-free food, because you can't always run out and find it. Well, what are the danger places? School. School is a dangerous place unless the school understands. And, you know, somebody has a birthday and they get a cake. Can't have the cake. Okay? Can't even have the crumbs. The teen years. Nobody wants to be different in the teen years. So as they grow up in the teen years, the danger of them saying, oh, I can just have, you know, a little bit of a hamburger or so on, and it'll make them sick and trigger their disease. Restaurants, dinner parties, and any unknown sort of cooking facilities. What are the resources available? Well, the internet's a good resource. Unfortunately, the internet, you know, in so many ways is a tribute to the First Amendment of our Constitution. But there's this magazine called Living Without, and that's a good resource and a good thing to recommend to your patients. There are support groups. Gastroenterologists are generally more aware of celiac disease than most people, but not always. And you need one that's not a scoper, just not only a scoper, but a thinker as well. And then other celiac patients and their families are pretty good resources. So if you have somebody in your practice and you can refer them or bring them in and talk with them, it's very helpful. Any social outings are a problem, peer pressure is a problem, medication's a problem, and as they say, eating out with friends is a problem. So celiac disease is a common 1 in 137, a sneaky, subclinical sometimes disease that we need to be thinking about. And I'm telling you, we're missing them in our clinic. And so we need to be aware of it, and that was the purpose today, was to make you aware of the disease, convince you that it's important, and tell you where and how you're going to find these people. And when you do, when you need help with them, we'll be glad to help you. Any questions about it? Yeah?
Should the patients with celiac disease be screened for diabetes?
If the celiac, yeah, I think probably it's reasonable to do a fasting sugar, but you've probably got that already anyway. I don't think I would do a glucose tolerance test or measure an A1C or, you know, anything like that. I think I would, but I would be aware of it. Yes, I think that's good. Any other questions? Yeah, John.
I didn't see on your list recipients or excipients of drugs, tablets, for example, and
yeah, it is. Gluten is used as a binder in medicines, and that's why I put on that site, gluten-free meds, www.glutenfreemeds.com, because that's a place that you can go and ask. So yeah, that's a big problem, because they may be taking a medication that has gluten in it, and that may be triggering their disease and be a real problem. Yeah, it's very, very definitely in there. Have you got for pediatric meds, do you have a list of meds that have them or has gluten or don't have gluten?
No, I've not seen it. I think it's certainly something to think about.
It'd be a great...
One of those covert.
Yeah, it is. It'd be a great article. You know, put together pediatric meds that have gluten in them.
Exactly. One additional thing, and that is, as a pediatrician, I think, you know, growth and short stature as an isolated sign. And I went through that with a family member, and after so many growth hormone treatments, didn't really do much. It was found that celiac disease.
Yeah, makes sense, doesn't it?
And it was laboratory biopsy proof.
Yeah.
And you know, so it as an isolated event, because at least I had always been taught that celiac disease always has diarrhea.
Yes, they don't. They don't. And that's what I was telling you about that lady with the single bowel motion a day. In fact, adult celiacs often don't perceive that they have diarrhea. They don't know that going 4 times a day and, you know, having 8 pounds of stool is normal. They think that's, but they've done that since they were small. So they don't realize it's different. And so we need to look for these clues. And, you know, you can imagine, here's this guy with iron deficiency has had several scopes, both ends, by gastroenterologists who have not thought about celiac disease. So it's there. The disease is there. We've got to go find it. It won't jump on our desk. They can have dental abnormalities. You know, the enamel of our teeth is a live tissue. And as the kids are developing, they get dental abnormalities. They get cavities and so on in their enamel on their teeth. And so that can be a real problem. Now, once they're treated and their adult teeth come in, it's usually not a problem. But so just something as simple as someone who comes in with terrible teeth and they're 20 years old and you wonder, do they have celiac disease? Any other questions? All right, go eat out, find some. Let me know.